Dr. Abhilasha BAHARANI. Dr. Abhilasha is a senior consultant and uveitis specialist at the NeoRetina Eye Care Institute in Hyderabad. She's also the South Zone representative to the Uveitis Society of India and editor-in-chief of the very reputed USI newsletter. She will be speaking on a very important topic of cataract surgery in uveitic eyes.
Thank you very much for the kind introduction, and I thank Dr. Tinku Bali and the scientific committee for this kind opportunity. Slide is not moving. Yeah. So cataract is the most common surgical indication in uveitis. It accounts for 40% of visual loss. 1.2% of all cataract surgeries are uveitic cataracts. About 60 to 80% achieve a best corrected vision of better than 20/40. However, the post-op best corrected vision is 1 to 2 lines worse than non-uveitic eyes. What is the pathophysiology? The deranged metabolism due to diffusion of toxins through the posterior capsule leads to the cataract. So the lens derives its nutrition from the surrounding intraocular fluid, and when there is uveitis through the posterior capsule, toxins might enter, and that is why you see the posterior subcapsular cataract as the most common type. In this talk, I'll be covering preoperative assessment and preparation, intraoperative challenges and techniques, and postoperative complications and management. Many a times, this is the eye picture that we see. And at this point, it's always important to do a B scan and look for any vitreous inflammation. Even if the vitreous is quiet, always look for choroidal thickness, because a thickened choroid might indicate an active inflammation in the eye. Assessment of visual potential, look at the optic nerve. This is a case of unilateral multifocal choroiditis with optic neuropathy. After healing, we see that there is a subtle disc pallor in the left eye. You see there is a disc pallor in the left eye, and when you do a visual field, you see a central scotoma. Many a times in cases of intermediate uveitis, while we are busy looking at the snowballs, we might miss the optic disc. Now here you see that the optic disc, there is a notch, and the patient has glaucoma. So all this assessment should be done prior to cataract surgery. Macula is the most important part, we all know. So look for a scar, a CME, an ERM, or even a macular hole. So when the media is hazy, as much as possible, now we have very good OCT machines. Always get an OCT done before planning cataract surgery. Now, hypotony is more difficult to manage than increased IOP. So intraocular pressure less than 6 millimeters, even when the eye is quiet. When there is seclusio pupil with normal IOP, always suspect that these patients might get hypotony post-cataract surgery. In children, people with white cataracts always get UBM done and look for ciliary body fibrosis and bands. And when they are present, please plan vitrectomy and not just plain cataract surgery. Hypotony can also occur in patients with poorly controlled inflammation prior to cataract surgery. Now, timing of surgery is most important. The eye should be quiet for 3 months. If fundus is visible, wait for as long as possible for full control of inflammation. Early cataract is indicated when you want to examine the posterior segment and when the cataract is very advanced, because it might lead to surgical challenges. Counseling, please counsel the patient about the visual prognosis, that the surgery might take longer. It's not a 10-minute surgery. Possibility of delayed visual recovery. Patients have to be insisted that they must continue their systemic tablets, because they might think after cataract surgery they do not need to carry on with the tablets, and they may not come for follow-up. Many of these patients are young, and they should be told about the need of reading glasses post-surgery. So etiological diagnosis is very important to control preoperative inflammation. About 83% of uveitis patients have an associated systemic disease. So unless we have an etiological diagnosis, we can never control the intraocular inflammation. So absolute and long-lasting control of ocular and systemic inflammation predisposes uveitis patients for satisfactory results. Coming to prophylaxis, now steroid prophylaxis is recommended in those who are at risk of macular edema or recurrences or hypotony, like in cases of VKH. Systemic immunosuppression should be stepped up 1 month prior to surgery, and this is the preferred approach. Oral steroids, if you are starting, please start at 1 milligram per kg, starting 3 days preoperatively, taper to preoperative levels at 1 month. Local steroids should be best avoided in the absence of an etiological diagnosis in case you have to proceed with the cataract surgery. Some infectious uveitis also have a propensity to reactivate after surgery, and these are toxoplasmosis and herpetic uveitis, and prophylaxis should be started for these conditions prior to cataract surgery, 1 week prior to cataract surgery. Now, the choice of surgery is obviously phacoemulsification, but because it causes less inflammation. When cataract and glaucoma both are present, cataract should be done first, because if glaucoma is done first and cataract is done later, the inflammation from cataract surgery might fail the bleb. When cataract and retinal problems coexist, a combined surgery can be planned. Anesthesia is surgeon's choice. I prefer subtenon anesthesia with a 23-gauge single port cannula. So in this video, I'll just show you. Just enter the subtenon space, and with the single port cannula, you can inject the lignocaine bupivacaine combination. Now, intraoperative challenges, these patients present with small pupil, shallow AC, posterior synechiae, peripheral anterior synechiae, pupillary membranes, and zonulisis. This is, so this video, this is one eye of the same, I'll show 2 eyes of the same patient. So the first eye, I have used iris hooks. So you release the posterior synechiae, and under subtenon block, I'll be inserting iris hooks. Here, you need not make a very long tunnel for the hooks. A short tunnel is enough. The hook should be inserted and tightened sequentially, not all at once. Because if you tighten all at once, it can cause large sphincter tears. I generally prefer a diamond configuration, because if you do with a square configuration, there is tenting of the iris when you enter with the phaco probe. A large capsular excess should be done. Phacoemulsification is not very difficult in these eyes. Removing the iris hooks is also very straightforward. While removing the viscoelastic, please take care to remove the viscoelastic even from behind the IOL, because retained viscoelastic can cause further inflammation in these eyes. So removing the viscoelastic thoroughly from the bag and closing the case. Complications of iris hooks. Iris hooks should be inserted and removed very, very meticulously. Here you see the iris hook has caused a puncture in the anterior capsule, and there is mushrooming of lens fluid. Here again, see the iris is tented in a square configuration, and the sharp chopper has hit the iris here, and then you see there is bleeding, and the entire surgery gets complicated. Remove the iris hooks carefully. If you see in the third case now, while removing the iris hook, a small tag of the iris is pulled out. So please take time during these surgeries. Coming to the second eye of the same patient, here I have used the B-hex ring. In a B-hex ring, you have to release the posterior synechiae. Stretch pupilloplasty has to be done. Insert viscoelastic above and behind the iris. B-hex ring has a little learning curve, but it's a very good procedure. I don't have any financial interest. It has flanges and notches, which have to be inserted in the pupil. And again, removing is also very straightforward. Once you learn the procedure, it's very easy to do. And again, removing the viscoelastic thoroughly from behind the IOL. So comparison between iris hooks and B-hex ring, pupil size and shape are almost the same, but shape is better for doing rhexis. There's a slight learning curve with B-hex ring. Surgical maneuvers are easier with B-hex ring. Surgical time is also shorter, and post-op pupil shape and size is comparable, and post-op astigmatism is also comparable between the two procedures. One question that is often asked is PI or no PI. So clear corneal phaco with large capsulorhexis without surgical PI is the preferred technique. But in pediatric uveitic cases, PI helps because these children have a tendency to develop glaucoma later in life. Acrylic IOL or heparin surface modified PMMA IOL are preferred. Multifocals are best avoided. IOL or no IOL, post-operative aphakia is associated with better long-term visual prognosis in children less than 5 years. But there are studies which have shown that good control, intraocular lens is not a formal contraindication, and about 80% eyes achieved a visual acuity of better than 6 by 9.5 when uveitis was quiet for at least 6 months. So post-operative complications and management, aggressive topical, oral and periocular steroid should be given, plus topical NSAID should be given. Posterior synecdoche and pupillary membranes can be avoided by keeping the pupil mobile. The principle is to over-treat and relax and not under-treat the inflammation and then try to catch up later. You can also have cocooning of the intraocular lens if the inflammation is not controlled. Capsular phimosis is also a common complication, but all this can be avoided with a large rhexis. Hydrophobic intraocular lens are preferred, and there should be meticulous removal of the viscoelastic. Post-operative CME, it's the most common complication. Incidence of CME in uveitic eyes with well-controlled inflammation is comparable to non-uveitic eyes. The risk is 6.7-fold higher in eyes with a history of previous CME. Behçet's is the most common etiology associated with CME, and the mean period is usually 7 months post-operatively. So at 6 or 7 months post-cataract surgery, be very vigilant, and risk can be reduced with post-op NSAIDs. So to summarize, etiological diagnosis of uveitis is essential for controlling the inflammation. The timing of the surgery is important. Counsel the patient about visual prognosis. Plan the surgery to manage the intraoperative challenges, and better post-op care can reduce the risk of complications. Thank you.
Thank you, Dr. Abhilasha. You've given some excellent pointers and shown some excellent videos on how to manage these patients with uveitis. Any question?
If you have got CME, so how do you treat that?
Okay. Thank you for that question. It's a very important question. So post-operatively, if you have a CME and it is a non-infectious uveitis, initially you can give the patient a topical non-steroidal anti-inflammatory Nepafenac for 1 month and wait for a month. You can step up the systemic immunosuppression. If the patient is, suppose, say, mycophenolate 2 gram per day, please make it 3 gram per day while monitoring the counts. If at 1 month also you see that there is fluid or there is subretinal fluid, then you can plan a posterior subtenon or an intravitreal dexamethasone.
So you said that in uveitic cataract you start steroid, oral steroid or whatever it is, so 3 days before surgery, and it maintain it till 1 month post-operatively. Uveitic cataract, now quiet and calm eye, the cataract is there, now there is no uveitis. Still you start steroid, or without steroid we can start?
Sir, if the patient has been quiet for the past 3 months, and if he is taking any non-steroidal systemic immunosuppression, you can step up the immunosuppression. Suppose the patient is on methotrexate, then you can increase the dose of the methotrexate. If you are not, if you cannot increase the dose because patient had disturbed liver functions in the past, then you can add a steroid. If you are sure that it is a non-infectious uveitis, then you can even give a local steroid. Okay, and if you are not very confident whether it is infectious or non-infectious and you are still going ahead with cataract surgery, then you can start the oral steroid. So then you can start 3 days before and then taper down to 1 month post-operatively, provided the patient is already on some form of systemic immunosuppression preoperatively.
I think he meant to ask that in a patient who's been quiet for a pretty long time and has a history of uveitis much in the past,
Even then we need to start
Yes.
steroids. Yes.
Any patient who's had an episode, it's a good idea to start.
Very nice talk, Dr. Abhilasha. I was just asking, in a hypotenuse eye which still has some visual potential, how much steroids do you give? How long to support the intraocular pressure? Let's say you're giving topical, you're giving subtenons, oral. How high do you go, and how many months will you keep carrying on before you really give up and worry that it's going into phthisis?
This is post-operatively you're asking, ma'am?
No, in general, actually, it was not necessarily post-operative.
Okay. See, for hypotenuse eyes with some visual potential, it is better to keep them on some form of topical steroid as well as systemic steroid. So systemic steroid, the dose should not exceed more than 10 milligram per day, because then you are putting the patient at risk of osteopenia and all the other complications of steroids. So 7.5 milligram the body itself makes every day. So you can give about 7.5 milligram oral steroid with maybe once or twice daily topical steroid and maintain the intraocular pressure. And when you think that the intraocular pressure is maintained for 3 months and there are no ciliary body membranes, you can plan cataract surgery. If there are ciliary body membranes present, you can plan vitrectomy with pars plana lensectomy in these
But let's
eyes.
say it doesn't pick up in 3 months or something. What is the time frame after which you would give up? If there's still a little visual potential left,
No, don't give up if there is visual potential.
then you give it
Yes.
indefinitely.
Yes.
And what is the lowest pressure at which you would operate? Let's say a eye with cataract has a pressure of 6 to 8 millimeter mercury. Would you operate the cataract at that time?
No, I would not operate.
Okay.
Because post-operatively these eyes might go down to really 2 or 3, and then it is very difficult to bring them back. So it is better to, if you control the inflammation, I have seen over a period of time, these eyes do come up to maybe 10 or 11, and then you are more confident in touching these eyes.
So you would not do below 10, you're saying? That should be a
Yes,
cutoff for us.
yes.
Okay, thanks a lot.
Thank you.
Bone implant works very well if you give a prior to
Yes,
push up the
before
pressures.
before surgery, but
Yeah.
then again after 3 months, it is better to see these eyes. It's better to follow these eyes for at least 6 months and see the pattern, how they are behaving. I generally don't operate if I see a patient for the first time
Yeah,
with a
of course.
cataract. So you see how the eye is behaving and then take a call.
For how long you keep these patients on cycloplegics post-op?
As if the inflammation has been well controlled before surgery, it's 1 week.
Okay.
Yes.
But we have seen patients, if we are taken off homatropine or atropine, there is tendency to flare up.
So that means the inflammation had not been under control in the first place. So cycloplegics will definitely not help controlling the inflammation. We need to step up the
Steroids.
systemic treatment. Yes.
Okay.
Good afternoon, everyone. Ma'am, increasing the dose of methotrexate, does it will not lead to increased chances of endophthalmitis because more risk of infection?
With local steroid, you're asking?
No,
sir?
no,
With
Methotrexate.
immunosuppressants, we
Immunosuppression.
Do we
No,
escalate?
no. See, when we
Doesn't.
are giving systemic non-steroidal immunosuppression, they target only a specific set of white cells. Steroids cause global suppression of the immune system. And because the eye is anyway an immune privileged site, we are not depending on the systemic things to control the inflammation in the eye. So we are not increasing the risk of end-off. End-off risk increases just like for all other cataract surgeries, like if the surgical time is long, you had a complication, all those things can increase the risk of end-off, but not these drugs per se.
Thank you, ma'am.
Thank you.
Thank you, Dr. Abhilasha.